move through these slides pretty quickly, and I'm happy to answer any questions that you have at the end. I have, I've been out in the field and working with groups and practices, and one of the things that we hear is that the physicians, really want to come to work and they want to practice medicine and they don't want to be involved in the business aspect of things. But the reality is, in order to be able to come to work and practice medicine, the doors have to be open, and so profit is very important in that aspect of things. For those of you who couldn't hear me before, this is the revenue cycle. You're probably very familiar with that. It's a little less traditional view of the revenue cycle, but I think it depicts the truer picture of what the revenue cycle really looks like. It starts with your fee schedule and really does end at the reimbursement analysis. And as far as the cycle, I have this slide up here just really to talk about one of the things that I see while I'm out in the field with the groups and practices and the client's feedback is that the most successful practices really do recognize that what happens in the revenue cycle is repetition. It's doing the same thing day in, week out, and at the end of every month, it's those same things. And if they miss that piece, any piece within the revenue cycle management 1 week or 1 day, that's really where you see the revenue cycle take a dive. So I just put that out there as a reminder. And then maybe just a little bit of a laugh of what a perfect revenue cycle should be. It should really be as simple as providing service, submitting claim, and getting paid. One of the other things that I thought was really important to discuss with this group, and depending on where you fall into working with your revenue cycle, whether you're an end user that's posting charges, posting payments, or whether you're administration, I find that a lot of times not everyone is aware of how the fee schedule is determined for your practices or your groups. So I just wanted to kind of mention that there are sometimes cost studies done that determine that fee schedule that you guys are using. Sometimes this is managed internally, and other times groups will reach out to a consultant to do that. And there are various different ways that they decide how to figure that fee schedule. Some groups base their revenue cycle, or I'm sorry, base their fees off of their percentage of Medicare. So for instance, 200% of Medicare is how they determine those fees. Others base it off of the RVUs. And then, of course, you have your highest payer, and others will use that as their baseline. But it's important for everyone in the practice to understand how those fees are determined, because you've got people that are negotiating contracts, and you need to know what the cost is to know whether it makes good business sense. And that being said, one of the pieces that I do find practices miss along the way is maintaining the fee schedule. So once it's been established, you really do have to be committed to updating your fee schedule every quarter or every 12 months, depending on what services you're offering. Most of your software vendors have a utility to go in and update those quarterly or annually. And if not, feel free to reach out to one of your consultants to make sure that doesn't become a manual process. It can take way too long, and your staff can be better used elsewhere. And many people do remember to maintain their fee schedule, but they don't load their costs. And those are important too, because if you're ordering medical supplies or you're ordering vaccines, you need to make sure that whatever it is that you're paying for those supplies or vaccines are getting reimbursed. So running reports at the end of the month, looking at your cost in comparison to your reimbursement, it gives you the luxury of being able to do that with a click of a report versus digging in deeper. And this has become a popular topic with the Affordable Care Act and the various different new health care payers that are coming out into the market, and changes in payment platforms. Your financial policies are becoming more important than ever. Some practices have very strong collection policies, and others not so much. And it really is coming to the point where the patient's out-of-pocket has become increased, their deductibles are increased, their co-payments are increased. There's, a lot of expenses to the patients right now. So your financial policies, you want to make sure that you're requiring them to pay their portion at the time of service. And a study that was recently done by MGMA still determined that 30% of the patients are walking out of your offices without paying anything. So keep that in mind. A little bit later we talk about some reports to kind of oversee that and manage that piece of it to determine how well you're doing with that. And then, of course, requesting payment at the time for elective services. If you're doing things that are elective, I think the patients fully anticipate that you're going to require those payments at the time. If you're unable to pay in full, if your patients are not paying in full, what is the minimum that you're going to accept? Payment plans and discounts for payment at the time of service is becoming very popular, but I always caution everybody when you're offering payment plans to make sure that it makes good sense. If your average cost to send a statement is $3 or $4 and the patient only owes $50, how long are you going to allow them to stretch that balance out? Are you going to spend as much sending statements as you're actually recouping? So a strong plan in place that kind of looks at that to make sure that you're not losing out that aspect of it is something that I encourage everyone to do. And then, of course, the patients have to understand what your expectation is. And where practices struggle with this a little bit is if they haven't always had the strongest collection policies, but they want to make a move that direction, you have to retrain your patients. That means posting it on your website. If you have a patient portal, it means advertising it out there that you're collecting at the time of service, including it in your new patient packets, your check-in and check-out areas. And then, I always encourage everyone that's making confirmation calls that you're reminding them that they have a balance due, or you're letting them know that you'll be collecting at the time of service. And this is just kind of a walk through the patient visit. I'm sure all of you are familiar with what that looks like, but the very front end piece of this is your benefit verification. And a lot of focus is being placed on the benefit verification. I recommend that you automate that as much as you possibly can. So if you're not automating that and you want to get some ideas as to how to do that, this would be a good topic for discussion at the end. And the reason being is, everyone kind of argues back and forth about when the billing cycle really does begin. Some say that it's the time that you schedule the appointment. Others argue that it's really when you're verifying the benefits, and then there are those who say that it really begins after the service is provided. And the truth is that if you don't have a service to provide, you really can't begin the billing cycle. So if you have large wait times in the waiting areas and the patient gets up and walks out, all of the work you've done that led up to that was really for naught because there's no billing cycle to take place. So everything that you do prior to that patient being provided the service really does determine how quickly you get paid within your cycle. And then this is just a little bit of an overview of some of the different categories that fall under the pieces of the cycle, and I get into a little bit more detail as we move through this. But under the service being provided, you've got your charge entry and charge audit. Under your claims, you've got your edits, reconciling the claims process, denial management and appeals. And then, of course, we have your payment being received. And some people think that that's where the process ends, but it really doesn't. You're going to reconcile those payments. You're going to perform a posting audit, and then you're going to do a contract analysis that makes sure that you're getting paid what you were promised to be paid. So that being said, on charge entry, I'm not sure how many practices are still out there that are doing charge entry process manually. This used to be a process where you had people that were heads down just posting charges all day, and that's kind of evolved. Most softwares are savvy enough right now to bring your charges over from the documentation that the providers are putting into their EHR. And really that's the optimal process, because the less staff time that you have to devote to that piece of the process, it keeps your costs down. And then, of course, there's the charge lag that always exists. Traditionally, it took sometimes weeks for physicians to get their charges in. And due to some of the meaningful use requirements and making records available for patients, a charge lag is something that you almost always have to eliminate. And most software vendors have a report that you can run where it identifies any encounters or visits that you've created and a charge does not exist. So I recommend that you have someone monitoring that on a weekly basis. And then, of course, knowing which payers have the timely filing limits. It used to be that timely filing limits were 1 year, and many payers have moved to 90 days, and some of them are getting to the point where they're asking for your claims within 30 days. So a charge lag can't exist anymore in the industry, and I encourage each of you to find that report that identifies where those charges are missing and work those routinely. The charge review, you know, this is one of those pieces where some practices do not use a charge entry process, and then there are other practices who do. I find that the most successful practices are those who do. So basically what this looks like, and it can be a quick 5-minute overview of what charges were entered. I always recommend a report that gives you the service item, the payer, the modifier, and I always recommend that you group it by the encounter or the data service. And the reason I say that is it gives you a quick overview of what's being billed together. And what I sometimes see happening is you may have a patient that comes in and they're coming in for a preventative visit. They may have had 5 immunizations. And when you do this quick minute overview together, you realize that the admin is there, but the vaccines never came over. And so it prompts whoever's doing that charge review to say, hey, wait, I see an admin, but I don't see the vaccines. And I typically recommend that a coder is the one that's reviewing the charge review, because if you have charges where a patient comes in for a preventative exam, they also end up having a problem and there's an E&M billed the same day, your coders are the ones that are going to be catching the fact that there may be modifiers missing. So again, it doesn't have to be a process that takes all day. It can be just a report that's set up so well that you can glance at it. Payer requirements are different. For instance, in California, some of the Medicaid HMO products are very specific, and they don't use the traditional CPT codes for some things. And a person who knows those payer requirements, or a coder who knows those payer requirements, looking at a quick glance at that charge review report is going to pick that out and realize that the charge was entered incorrectly. And these are really your best people to tell you if there are edits that are missing in your system from stopping things from going out the door. So again, I recommend having that charge review process implemented into your process somewhere. And then a charge audit is simply just making sure that for every service that was provided, a charge is submitted. Again, that leads back to having an unbilled charge report. And then one of the things that a lot of practices don't have built, but I recommend, is building a charge report that looks at your total units, and it looks at your charge equal to 0. And all you're really doing is looking for any charge that was entered where a fee had not been attached. And sometimes what happens is when people are in building your service item libraries, they'll load the code but not know necessarily what fee is to be charged. And so they're following up with someone on the other end, but meanwhile charges are going out at 0. So it's another good report to put in place. And that leads us into our claims. So claim edits are a big deal these days. The more claims that you can get out the door clean, the better. And a lot of times that's done through your internal claim edits that are loaded into your software product. And if that's not happening there, then your clearinghouse is usually the next place that your claim edits will stop. And I find it interesting, a lot of times what will happen is you have staff, end users, that are working your clearinghouse rejection report, and they're making the corrections and they're correcting the same things day in and day out. And so I encourage people at the management level to ask them each week, what types of things are you fixing? What do we need to fix on our end? Who do we need to educate? Because if you're just simply correcting, that staff is going to be busy the next week and the week after doing the same thing day in and day out. And really you want to shift those resources to enhance some things at the end of your revenue cycle versus getting the claim out the door. Your payer acknowledgments, a lot of the payer acknowledgments, it used to be that you would have to call the payer and find out if they had the claim on file, and that has moved to a more automated process. If you're still calling the payers to find out if they have the claims on file, you need to look at some of the tools that you have within your software to go out and grab that information and populate it into your system for you so that you can see that at a glance. And again, online claim status, your clearinghouse, your software, please make sure that your staff, and ask them. Sometimes your staff isn't aware of what the system is capable of doing, and they may still be out there checking claim status online. We've seen staff members that have said, yeah, I'm still going out to the website, and they didn't realize that they needed to alert someone that they were doing that and get the system adjusted accordingly. Denial management is a big one. A lot of the denial management used to be so manual, and really that can be completely automated at this point with your software. If you have payers coming in with rejections and they're using the reason code, you can create tasking within your software system to generate and have different groups working those denials almost immediately. And they really should be addressed within 24 hours because, you know, once your claim has been rejected, you've added 45 to 60 days onto your revenue cycle as far as turnaround time for your payment. So go a step further in that process. Once you have gotten the denials automated and you're tasking them out to different groups and having them work through those within the 24-hour period, the next goal is to analyze what denials are coming through to be preventative. I find practices that, you know, are still finding staff working the same denials, and really if we're talking about the denials and we're enhancing the system or being preventative to make sure that the claims are getting paid the first time, it really does speed things along for your days in AR. And then, of course, appeals. Again, I recommend that that process be very automated. You need to make sure that you have appeal letters that are ready and handy to mail out to the various different carriers. Find out which carriers require the appeals to come electronically and try to automate that process as well. The less time that your staff's spending doing the manual pieces, the quicker your revenue cycle is going to work through. On payment reconciliation, going now to the payment actually being received, the payers are almost exclusively now all ERA. So I usually recommend that people just do a check and balance of how many payers are still sending you paper checks. And if they are, contact your clearinghouse to make sure that you can get those moved to ERA. And if your payers aren't, don't be afraid to pick up the phone and let the payers know that they really should be at that point and find out what they're doing to move that direction. If you can get those payments coming in electronically and automatically posted without staff having to do that, that just means you're doing a check on the back end, and it's a quicker process to make sure that you speed that along. And then, of course, you know, ERA, one of the things that I like to throw out there, because, you know, some practices do not allow their staff to have access to their financials, and understandably so. What tends to happen sometimes is I find practices where they're posting those ERAs without having confirmation that they've hit the bank. And so you really do need to make sure that you have a process in place that tells your staff what ERAs have been received into your bank and what they're okay to go ahead and post. If you allow them to continue to post those without that confirmation, you run the risk that the funds were never received, and you don't usually find that problem until it's too late, and then you're kind of digging out to recover the money. In posting audits, again, this is another controversial topic as to whether practices want to spend the time to do a posting audit once you've received the payments. But I really do recommend it, because what sometimes happens when you do automate processes is that you have to make sure that your system is maintained. You don't want things that are taking adjustments simply because the reason code said lack of information. You want to find out what information those payers are needing and get the claim back over. And if your system is set up so that it adjusts that automatically, you miss out on that revenue if no one's going behind it and checking. So I do recommend a daily payment audit, which is just simply running the payment report, looking at how the payment is settling the balance or moving that balance. Is it moving it to the patient appropriately? Is it moving it to an appeal appropriately? And are adjustments being taken, and does that need to be remedied? And then, of course, as I mentioned earlier in the presentation, your billing cycle, your revenue cycle, none of that really ends once the payment's received. You need to be aware of whether or not you're being paid according to your contract, and this kind of goes back to the fact that you want to have your contracts loaded in your software. You want to have your costs loaded in your software so that all of those reports that tell you whether you're getting paid above your costs and getting paid your contracted rate are all on the up and up. There is a report that I recommend practices run, and it's basically that your payment amount is equal to your charge. And that says, hey, you're being reimbursed at 100% of what you're charging. And the reason I recommend that is because there are many times where you'll bill a charge out, and if the carrier is paying it at 100%, maybe your fees are set too low. And you really need to keep an eye on that to make sure that you're recovering everything that you possibly can from those payers. And then the other piece of it is where you have paid above your costs. If you weren't, that needs to be addressed with the payers. And sometimes those payers will come back in and ask for an invoice, for instance, for a drug, if they've paid you less than your cost. And once they've received the invoice from you, that'll justify for them to go ahead and give you the increased payment. But you really do need to keep a close eye on that. And so the next part of the presentation is really just talking about managing those pieces that we've just identified. Again, I'll go quickly through some of these slides just because we've talked about the fee schedule, but you really want to identify where the ownership is within your practice. Some of the end users, as I'm out in the field, they're not sure who comes up with the fee schedule. So if they see that something is kind of out of whack with the payers, they don't know who to provide that information to. So you want to make sure that communication is out there for your staff throughout your organization. And negotiating the payer contract, again, whoever's doing that negotiating really needs to understand that fee schedule. And what's the cost compared to the payers allowable when you're negotiating the contracts? And there are indirect costs that are involved. If they have higher denial rates, it means it's costing you more to submit a claim to that payer than your profits declining. Are they a payer that typically appeals more of your claim, or that you are required to do more appeals on your claims? One of the trends that we've seen is that a lot of the payers are moving to paying with a credit card, and there are fees that are associated with that. And if you're having to eat those fees, it dips into what your profit is. So make sure that you take those things into consideration on what is the administrative burden for doing business and having a contract with the payer. Another important piece is if you're negotiating a contract with a payer that accounts for 40% of your business as opposed to 3% of your business, that's going to be a very important piece to take into consideration when you're talking about what their rate of reimbursement is. And then last but not least, on the negotiating of the contracts, I know we're all familiar with the old term of evergreen. Some payers still do renew your contracts without you needing to sign off on that, and you want to make sure you eliminate that. So call your payers and find out which of your contracts are currently evergreen, and make sure that you get those adjusted to where you need to review those each time they come up for renewal. Your financial policies, I think it's important to communicate throughout your organization who is responsible for developing and maintaining those policies, and who's responsible for execution of those financial policies. As things change, your financial policy will probably need to change. It's important to keep that updated. And your benefit verification process is part of your financial clearance. This is probably one of the biggest, most important pieces to your business right now. I also recommend that that process be automated as much as possible. You should not have staff that are on the phone calling the insurance carriers because it does take a lot of time, and it takes a big part of their day. You want to move to relying on your software vendor or a clearinghouse to make sure that process is being able to be done ahead of time. I recommend usually 1 to 3 days prior so that you can identify patients who maybe don't have coverage, or possibly that their coverage has changed, so that you can communicate that before the patient comes in and is in front of you. And then, of course, the best way to evaluate how well your staff is doing, how well your practice is doing is to look at your denials that are related to your eligibility. If you run a report and you base it off of a reason code coming in from the payers, you'll be able to identify all of those reason codes that are associated with eligibility, and it'll tell you if you have a hit or a miss for any given period of time. And then communicate the expectations to the staff as well as the patient on, what happens if they do not have coverage. What is your staff required to tell the patient? And, if the patient finds themselves needing treatment, but they haven't been able to clear up their insurance information, just make sure that your staff has a really good idea of how to handle that. Execution of your patient obligations. Just make sure that, again, the patients are aware prior to the visit. Require your staff to collect it. And part of the management piece is just to evaluate what the success rate is of what they're doing. I always recommend to look at a report, maybe your 0 to 14 days, and look at the past couple of weeks to see what balances have been moved out to the patient. Are they deductibles? Are they co-payments? It's possible that there are procedures that are not covered, and maybe your staff wasn't aware of that, and they're just not collecting it because they don't know. So evaluate that piece. And again, a lot of these pieces of the cycle are a weekly process or a monthly process, sometimes daily process. And as we talk about some of these pieces, you'll want to determine how often you're currently doing it, and do you want to kind of escalate that to doing it in a shorter period of time. I've thrown some tools out here that have become popular for patient financial responsibility. With your merchant services, there are a lot of things that you can do with your software. You can have a credit card processor that's completely integrated. Same thing with a check scanning device so that you can scan your checks that you're receiving in the office and scan those over to your bank. Create a posting batch without somebody having to manually post them. So if you're not currently doing that, definitely check into trying to automate that a little more. And then, of course, your eligibility tool. If you have an eligibility tool that is integrated with your software, that's a good way to go. But if not, you can then always lean on your clearinghouse and have the clearinghouse take a look at what it would, look like if you were to integrate with the clearinghouse on performing queries in bulk, doing it in advance. And then there are some patient portion estimators that are out there. You can definitely check into that as an option so that you're capturing more of those patient receivables. If you're finding that a lot of your receivables aren't being collected, that's definitely something that you could take a look at. And then, of course, having a patient portal. Your patient portal allows them to make monthly payments online. It allows them to pay their bill online, access their accounts. And so it does take the load off of your staff from receiving the phone calls about their bills, to take payments, to explain what the balance is a result of. Just taking that load off of your staff. It decreases your costs. When we look at managing the patient receivables, review and analyze the receivables weekly from the previous week, again, to determine how effective the collection process is going, and analyze a report of the patient aging based on the date that the patient became responsible. A lot of times, if your reports are set up to run based on the date of service, clearly it makes it look like the patients have, excuse me, have owed those balances much longer than they really have. And again, when your patients have owed the balance for 90 days, excuse me for 1 second. When you have a patient AR that's greater than 90 days, you want to keep that less than 10%. If you get much higher than that, you really do start to see your revenue cycle deteriorate. I always recommend that your patient balances be referred to a collection agency at 91 days. After 91 days, the collectability decreases. It used to be you would have to have someone going in and looking at those balances and manually moving those over to your collection agency. You really can automate that process. So if you're not doing that, that might be something that you'll want to consider to move that process along a little more quickly. And then anyone who's involved in the collection process from the front end to the back, you really do want to share with them where you're at as far as that 10%. Are you at 20%? Are you at 15%? Or are you really doing a good job and you're at 8%? If the staff is involved in knowing whether they're being successful, it really does help your cause. And then managing bad debt, I find that a lot of times practices and groups stop looking at their receivable once it's hit bad debt, but you do want to reconcile your bad debt with your practice management software and your collection agency just to make sure that all of the balances that you're referring are getting there. And then, of course, monitor the collection agency's performance. We talked a little bit about the charges. I always recommend that you solicit feedback from your staff who are performing the charge process. If they're doing a charge review and they're having to make changes, what are they changing? Is it because your system is set up incorrectly? Is it a workflow issue with the providers? Whatever it is that they're manually changing, make sure that you get those addressed so that it cuts down on the time that they have to spend with that. And again, managing the report on the charge lag and the unbilled charges, a lot of practices have decided to share that information with the physicians as far as how they compare against their peers with the number of charges that aren't yet submitted. And if that's not a good idea for your practice, at least providing them with a report card specific to them. Of course, your claims. Again, we talked about this a little bit earlier, but one of the things that needs to happen is when you're sending claims out the door, somebody needs to be reconciling those with your clearinghouse, making sure that what has gone out the door has been received. And then, of course, monitoring the clearinghouse rejections. I've seen practices where they had a person identified that was working the clearinghouse rejections, and when we went out and looked, they weren't actually being worked. So someone just needs to manage to make sure that those are being done daily. And then, of course, getting the feedback to make sure that those are actually being prevented so that they're not being worked over and over again. Your denials, I always recommend that you identify your denial percentage in comparison to your charges on a monthly basis. And really, it should be less than 2%. So if you're above that, that's where your denial analysis really becomes powerful for you and your group. Again, evaluate what's being denied weekly. Take action to prevent the same denials in the future, and monitor the action taken on the denials. Are they worked within 24 hours? And are they producing a payment after they're working it? If you have payers that aren't paying quickly after the denials, all of that information is key every week so that you know who you have to be on the phone with and push to get that changed. We talked a little bit about posting. When we're talking about if you're running a report and you're looking at balances that are being settled to the patient, are they being billed appropriately? Are the adjustments appropriate, and are the payments reconciling with the receipts? Contract analysis, we talked a little bit about making sure you're paid according to your contract. Are you being paid at 100% of your charge? And again, we talked about a report to use for that. But evaluate those fees and increases as appropriate so that you're not leaving money on the table, and make sure that you're being paid more than your cost. And the biggest thing that I would say to you and your groups and your practices and your providers is to communicate results every month. Talk about them. Talk about the key indicators, some of the things that are big key indicators for the groups are the days in AR. Your denial percentage, of course, is important. The percentage of your AR over 90, whether it's by payer. And then, of course, you have to separate out your patient. And there really should be two different percentages that you're looking at. Your charge lag. There are other things that are very important in some of the practices. And if you put together a package of those key indicators at the end of every month for everyone to review and talk about and be a part of, it makes everyone feel like their piece of that they can really share in the success when you're at that point. So I think that's a huge important piece. If you don't have something like that you guys are putting together manually, and you find that the reports that your software produces isn't really to your liking, please reach out to a consultant to put it into a comprehensive document that you can share each month, because you have to know where you are to know where you're going. So I guess with that being said, I'll open it up to anyone who may have some questions. I did get a question about sharing the PowerPoint slides, and we absolutely will do that. We will send out something following this presentation, a link for you to access those. So we'll definitely make sure that you get those. And then for the revenue cycle management software, I got a question about which software are we using. Most of what I've discussed today is really things that you can pull from your system. There's different ways to run the various reports, to zone in on some things that maybe, for instance, I'll give you an example. If you run an aging report and you look at it by payer and you find that one payer is just off the charts with the percentage over 90 days, it really does help to kind of know how to look at sometimes you want to sort it by a service item to find out if a payer is denying one service item over another. And if so, drill into those and look at what they're missing. I'll give you an example of this. I had a group that was having an issue. Medicare was the payer, and we ran the aging by that specific payer and sorted it out by procedures, and we found out that there were CLIA numbers that weren't actually going out on the claims. But you really did have to sort those reports to get a quick jumping off point of where your problem was pointing to. So a lot of it has to do with how you're running the reports. And you can certainly reach out to me with some questions on that if you have specifics. Let's see, what else do I have questions on here? Is there a training course available for revenue lifecycle management in healthcare? You know, there are a lot of things that are published out there online. If you have some more specifics, please don't hesitate to shoot me an email at the email address that's up on the screen, and I can give you some more specifics and give you some more direct guidance if you have some specifics on that. Is there anybody else that might have some questions? I have a few that were coming through the chat. I think I've answered all of those. You're more than welcome to unmute your line, and I can answer questions that way, or you can keep sending some questions through the chat. Okay, guys. Well, if there's nothing else, I will go ahead and wish you guys a good afternoon. And like I said, we'll make sure that we get all of this information over to you following the presentation. All right, thank you. Have a great afternoon.